Right, I make it just gone past 12 o'clock, so let's make a start. Hello, everybody. Welcome to Learning at Lunch again. This session will be recorded, and I'm working this afternoon to actually get all these videos onto our new YouTube channel, so you'll be able to see them on there as well if you weren't able to make this directly. So for the next 20, 30 minutes or so, we're going to be talking about ARDS and Proning. So acute respiratory distress syndrome. So what can cause an ARDS type situation? Well, there's lots of different things really, but you can bracket them into two separate causes. So you've got direct lung injury and indirect lung injury. So a direct lung injury would, for example, be fractured ribs. So you've got bruising to the lungs, or you've got ribs that have actually hit the lungs and cut the lungs, or you've got an aspiration. It's a direct lung injury. So it's injury actually physically to the lung rather than, and why are my slides not moving? Hold on, let's get rid of that. Here we are. Rather than an indirect lung injury. So the other causes, and probably one of the main causes for us in ITU, certainly at Heartlands Hospital, would be sepsis. So those little bacteria there on the left-hand side of the screen. They can cause lots of problems, and one of the problems they can cause is the ARDS type picture that many of our patients present with. Another cause can be problems with the other organs. And we've got, for example, here the pancreas. People who have a pancreatitis get a lot of inflammation. That inflammation can cause a lot of problems with fluid leaking into compartments it shouldn't be in. And one of those compartments can be the lung. So anyone with a pancreatitis could be at risk of an ARDS type picture as well. People with liver disease can also be at risk. So major injuries really to any of the organs which causes an inflammatory response can go on to affect the lungs themselves. And then finally, something like a trauma, so a road traffic accident, where organs are damaged and the immune system goes into overdrive, or we give patient lots and lots of blood. That can cause patients clotting problems, and this can go on to lead to problems in the lungs as well. So those are the kinds of causes of an ARDS type response. So if we just go down to the alveolar level first and foremost, because this is where the problem is occurring mainly. So you can see on the left side here, I've got an outline of the alveolar, and on the right side, the alveolar is in a bit of trouble. So just to recap, the alveolar itself has got a very thin epithelial layer, 1 cell thick, as has the capillary that goes around it that's carrying the blood. It's 1 cell thick because this allows for nice, fast diffusion across a very thin membrane. So the 3 requirements for good diffusion across a membrane are a thin membrane wall, a big surface area, and our lungs have got a very big surface area, and a partial pressure difference. So is there a big difference in partial pressures between the gas coming in to the alveoli compared to the gas that's in the circulation? So how do we turn up the partial pressure? We turn up the oxygen. That's effectively what you're doing. So the other structures you can see there. So you've got the surfactant, which is very important in the alveoli. These stop the substance stops the alveoli from collapsing every time we breathe out, which would then require more energy to then breathe in, and that's secreted by those type 2 cells that you can see there. And then the capillary going around the edge of it, you can see it's got some small gaps in the capillary wall, but they're not very big, they're not very substantial. And then obviously the red cells, amongst other things, are floating through the circulation past the alveoli. So what happens in ARDS? Well, there's a number of processes that occur. So if we kind of take it from the top, so you can see that we get things like pulmonary edema start to form. And this is because you start to get big gaps in the circulation. As you can see down at the bottom now, I've made some of those gaps a little bit bigger. Vasodilation makes that occur. Those gaps become a little bit bigger. Fluid starts to shift where it shouldn't be going. So the patient will start to develop a pulmonary edema. The type 2 cells, those ones that secrete surfactant, will be damaged. So your surfactant production will also be reduced, which means that those alveoli are more likely to collapse at the end of expiration, making it A, harder for the patient to breathe in, and B, you're reducing the surface area for the diffusion process to take place. You've got now a bigger gap between the alveoli and the circulation as well, because the fluid doesn't just go into the alveoli itself, but it also goes into that space between the alveoli and the circulation, the interstitial space. So when we talk about interstitial lung disease, that's the area we're talking about, and that makes that gap bigger. And remember, I said that diffusion is best when the membrane wall is as thin as possible. Now we've effectively made that membrane wall a lot thicker, so diffusion is a lot slower. You get something called a denuded basement layer of the alveoli, and this is just a layer on which all the other structures hang, so that kind of compromises the alveolar itself. And because you've got these larger gaps in the blood circulation layer, you allow things like neutrophils to work their way through into the interstitial spaces, which the interstitial space doesn't like. And as a consequence, in the long term, you'll start getting things like fibrin and collagen deposition in the interstitial space. Now, if you've ever looked after an ARDS patient, or indeed if you were with us during COVID, you'll know that what happened with a lot of the COVID patients is that their lungs just became stiffer and stiffer and stiffer, and they were less and less able to clear their carbon dioxide. And that's because of this fibrin and collagen deposition. The other day, I was talking to somebody about the elastic tissue around the alveoli. I think it might have been you, a leader, actually. I was talking to somebody anyway about the alveoli and the fact that they rely on the elastic tissue to recoil, and that recoil makes sure that your carbon dioxide can be breathed out. If you've got this fibrin and collagen deposition, the lungs are becoming stiffer and stiffer. The elasticity is lost, and that means that you're not going to be expelling that carbon dioxide as well as you need to be. The other issue that occurs as well is you get platelet aggregation. Now, in and of itself, that's not a bad thing, but the problem is that in something like ARDS or an overriding sepsis response, the platelets will aggregate in the wrong places. So you'll get clots in the lungs, but because they've collected there, not really where they're needed, you then get bleeding elsewhere. And this is a condition called disseminated intravascular coagulation. So platelets are filling up gaps they don't need to. They're not where they should be. And as a consequence, you get this DIC type picture where the patient is both clotting and bleeding at the same time. So that's essentially what's happening in ARDS. There's a number of definitions of ARDS. It has been updated very slightly only recently, but I won't go into those details because it doesn't make a massive difference to the way we work. So we define how severe somebody's ARDS is by their PF ratio. So what is their PF ratio? The PF ratio is basically the amount of oxygen they're on divided by the FiO2. The PF ratio is the PO2 divided by the amount of oxygen they're on. So the PO2 that they've got on their blood gas divided by the amount of oxygen that they're actually on. Now, if you're in America, you work in millimeters of mercury. So I've converted these for those sensible people like us who don't work in millimeters of mercury, although their figures look much nicer and tidier. So if it's a mild ARDS, you're talking about a PF ratio of 40, or in their language, less than 300. So anywhere from 200 to 300 would be considered a mild ARDS. We generally don't see mild ARDS patients. They're not sick enough to get to us. It's only really once they hit the moderate and severe that we start to see them. So the moderate is anywhere from 27 to 13 or 200 to 100, and then severe would be greater than 100, less than 100 or less than 13 kilopascals. The important thing with the definition as well is that it has to be an acute onset, and there has to be a non-cardiogenic cause. So what do I mean by that? If you've ever seen a patient in heart failure who's gone into pulmonary edema, you can see that quite clearly on the chest X-ray. You get this bilateral fluffy picture on their chest X-ray. But you know that it's probably a cardiac cause. So they've got a cardiac history, they're coughing up pink frothy sputum, etc., etc., or they've just had an MI. If they present with that kind of picture, though, this bilateral fluffy opacities on their chest X-ray, and they're not known to have any cardiac issues, you've perhaps done an echo and their ejection fraction's absolutely fine and there's no cardiac history, but you perhaps are presented with a symptom like sepsis or a pancreatitis, or they've been they've had some trauma, then you have yourself an ARDS. So, there's cardiogenic and there's non-cardiogenic pulmonary edema. That's the way it's defined. So a non-cardiogenic pulmonary edema is ARDS. The lung is full of fluid, but it's not the heart that's causing the problem. It's circulatory issues secondary to things like sepsis that are causing the problem, which are overwhelming the lungs with all this fluid. So just to quickly, and we'll talk about proning in a moment, but just to quickly talk about some of the guideline recommendations for the treatment of ARDS, because there are a number of things proposed way back when about how we're going to treat this syndrome. And the Intensive Care Society have produced their guidelines with their recommendations. So if we start from the bottom, extracorporeal carbon dioxide removal. They're just recommending further research on that. So we actually, to put a patient on the ECMO and deliberately remove their carbon dioxide from their blood, that's effectively what you're going to be doing. So you're not just adding oxygen, you're actually removing the carbon dioxide as well. They make a research recommendation for that. Corticosteroids, again, research recommendation. So what they're saying is there isn't enough evidence when they produce these guidelines. There perhaps needs to be more, and I think that's ongoing. I'm sure these studies I've heard about that have looked at that very specific topic. Inhaled vasodilators. There was a time when I worked in cardiac ITU where we used to put patients on inhaled nitric oxide. It was said to help with vasodilation and clearing up oxygen-free radicals, blah, 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 blah. But actually, the guidelines here say that they're probably against this. They don't think it necessarily helps. ECMO, weakly in favour. You know how hard it is for us to get our patients to go for ECMO, but the ICS guidelines say, yeah, worth a go. Our patients have to be they have to hit a window, really, don't they? They have to be really sick, but not too sick, because if they're too sick, ECMO will say they're too sick. If they're not sick enough, they'll say the same thing. So they have to kind of hit this window, which is fair enough. They've obviously got their parameters when they know it does work and when it doesn't work. Neuromuscular blocking agents. So a lot of our patients will end up putting on these blocking agents, will end up paralyzing them. ICS is weakly in favor. Ideally, for no longer than 48 hours. The problem is if you extend it beyond 48 hours, you then start to have problems with the patient developing muscle-acquired weakness. When they wake up, they can't move. You're not even sure they're awake because they're simply not moving anything. And then when it comes to walking and breathing, it becomes very difficult for them. Again, during COVID, some of our patients were paralyzed for days and days and days because as soon as we turned the paralyzing agent off, they just wouldn't breathe properly. Higher peak end expiratory pressure, so a higher PEEP. We tend to use PEEPs of between 5 and 10, don't we? But there is some evidence that actually in patients with a moderate severe ARDS, you should be going up to PEEPs of 12, 14, 16, 18. Because the problem is if it's taking an awful lot of pressure control to inflate those alveoli, let's say the pressure control is up to 20 before they really open, then there's probably no point in letting them collapse to below 20. You might as well just keep them there and then reinflate them from there with a very high PEEP. Don't see it done very often over here. Highest PEEP I've ever used is probably 14. But there were some documents out some time ago saying that they should be done higher than that. Conservative fluid management, again, weakly in favour. We are worried that these patients' lungs are drowning in fluids, so we do try not to give them too much fluid. Excuse me. But again, sometimes you can't avoid that because they just need the fluid. High frequency oscillation. I've never seen this done. These high frequency oscillators, basically, it's not pushing a volume of gas in. This membrane just oscillates at a very, very high frequency, and it's that moves the gas in the patient's lungs. There was 2 trials done, both of which had to be abandoned early because it was actually shown to cause harm. You may see it in children's departments still. I think they still use it in pediatrics, occasionally in ITU, but we don't use it on adults anymore. But the 2 that they're strongly in favour of, and there's good evidence for both of them. So first of all, that is the lung protective ventilation. So ideally tidal volumes of 6 mils per kilo, 6 to 8 they say, but 6 mils per kilo if you can, and avoid a plateau pressure of greater than 30 centimeters of water. And just be careful next time you see me, if you want me to tell you what the plateau pressure is, it's not the peak pressure that we record on our ventilators, but I can show you how we can measure it very easily. So sometimes you'll see a peak pressure of 32, 34. I'll come along, I'll fiddle with the ventilator and say, yeah, that's fine. The plateau pressure is 25. Well, next time you see me, just ask me to show you how I do that and why it makes a difference. And this is what we're going to go and talk about now. Prone positioning. They're strongly in favour of prone positioning. But there are papers out there say you should prone for greater than 12 hours per day. And there's some papers that say it should be up to 16 hours per day. And that indeed is our practice. When we prone our patients, we try and prone them for 16 hours, then turn them on their back for another 8 hours, and then prone them again. And ideally, especially if there's a response, you should be proning the patient fairly regularly. I've seen them done 5, 6, 7, 8 times. And sometimes you can still get quite a good response to it. So that's the reason why we do proning. One of the earliest studies regarding proning was the ProSiva trial. This was a French study, French and Spanish. They had 474 patients who were prone for at least 16 hours. And this was done for 28 days or until an improvement was an improvement was shown. And it was for moderate to severe ARDS who were mechanically ventilated. And the big number that came out of this was the 28-day all-cause mortality. So those who were proned regularly, there was a 16% mortality. Those who weren't, there was a 32.8% mortality. Now, the problem with this study, and it's often been quoted, is that there was a lot of patients that weren't included. So were they being a bit too selective? The SOFA score. The SOFA score is a measure of how sick a patient is, how septic they are. So the higher the score, the more septic they are. And there was a slight difference between the two groups. There was a higher use of vasopressors in the uh, prone in the prone patients versus the unproned patients, and there was actually lower use of neuromuscular blocking agents in the prone group versus the non-prone group. But the main thing is that, and this was done pre-COVID, this study, I think it was 2014, something like that, 2016. All of the teams had greater than 5 years experience of proning quite regularly. Now, I would say that most UK teams, and I suspect quite a lot of worldwide teams, had little to no experience of proning prior to COVID. I think I'd done it twice before COVID, and I've been in ITU for 30 odd years. But during COVID, obviously, we did it a lot more regularly. We became much more practiced at it, became aware of the pitfalls and the safety issues, and did a lot of it during COVID. So we perhaps caught up with the Proceiver crew now anyway. And then there's this study here, which actually was another study done a little later on, 2017. So this was a systematic review and meta-analysis. So they've gathered all the papers together that talk about prone positioning, and kind of collated all the results and come up with some findings. So there was 8 randomized controlled trials with over 2,000 patients. And actually, the meta-analysis showed no difference in mortality, but the important thing was that the subgroup analysis did show a lower mortality for those who were prone for more than 12 hours and for those with a severe ARDS as opposed to a mild to moderate. So I think that kind of ticked a lot of boxes for the proning fans amongst us. And I'm certainly a proning fan. I've seen it work very well, as I'm sure some of you have as well. So that's why we prone. What are we doing during proning? What effect does it have actually on the patient? Right, so now you're looking at the patient. Imagine they're in their CT scan, okay, and you're looking at their feet. So you're looking at the perspective of them from their feet. So you can see the right lung there and the left lung there in a nice closed box, and the little circles are the alveoli sliced, if you like, as would the CT scan. So they're all nice and circular, nice and equal. But there's a bit of a problem with that, because one of the things that our bodies are subjected to is gravity. So as we lie on our backs, those alveoli stretch. They often call it the slinky effect in the research papers. So if you know what a slinky is, imagine holding it from your hand and dropping it, then most of it will drop down to the bottom, won't it? And that's the same with the alveoli. So the ones on your chest, if you're lying on your back, are not being affected too much by anything above them, whereas when you get towards your back, the alveoli are being a little bit squashed as you lie on your back, so they're not able to take part in gas exchange quite so easily. But we also have the problem that our lungs are a bit of a strange shape. So they're not actually a box like I've just shown you. They're more like this teardrop shape that I'm showing you here. So again, the patient's been sliced in half. You're looking up from the feet, right lung, left lung, and they're lying on their back. The effects of gravity mean that because there's bigger space at the bottom than there is at the top, because it's pointy at the top, then most of the lung will fall down into the bottom of the lung. Meeting will end in 10 minutes. I should be fine. We do get a cutoff, just rejoin. I should be done in 10 minutes. So most of the alveoli will drop to the bottom of the lung. Now, remember that our patients have got lungs full of fluid, and that fluid will settle down to the back of the lung. So now you've got these squished alveoli at the bottom of the lung lying in all this fluid. Perfusion doesn't really change whether you're lying on your front or your back. The blood supply is exactly the same, pretty much, whether I lie you on your front or your back. So the blood supply is unaffected by the position that you are lying in, but not so your lungs and the fluid that's in your lungs. So if we turn you over, because of the pointy effect of the lung, less of the lung can fall now, because there's not so much room because of this pointy lung, if you like. So now we've got more open alveoli at the top of this picture, if you like, still at the back because now the patient's on their front, and less of those alveoli are now sitting in this fluid, which is now drained to the front of the patient. So we've got better perfusion and better ventilation, which means that the gas exchange will be more effective. The other effect that it has is your heart. So if you are lying on your back, which is the top image, your heart is very slightly closer to the front of your chest than it is to the back of your chest. So if you're lying on your back, your heart then actually rests on your lungs. It's kind of sitting on top of your lungs. Not its entire weight, obviously, because it's being held in place by lots of other structures as well, but some of it is sitting on top of your lungs, squashing your lungs even further. If I now lie you on your front, your heart then rests mainly on your sternum, and takes a lot of pressure off the back of your lungs. So you can see that in these images here, and I think you can see it reasonably clearly in these CT scans here. So you can see here that this heart is kind of sitting on top of all this lung here. And then this heart, when they're flipped over, is now sitting on the sternum. And again here, and you can see this lung has started to clear because the heart is sitting on the sternum and the patient has been proned. And then the other effect is that this is meant to be the patient from the side, by the way. That's their torso and their legs. I know I'm not an artist, but I think you get the idea. So if you're lying on your back, you've got your diaphragm, and because of gravity, a lot of your lung will just fall backwards against your diaphragm. Now, remember, this is the area that's got all the fluid in it as well, and all these squished alveoli, and now you've got your bowel on top of it as well. As you can see here. So the next diagram shows what happens when my order of diagrams is, oh no, screen sharing has stopped. Okay, so just imagine that image now. This is why we tilt our patients very slightly, because what we want is we don't want those bowel contents to be pressing on the diaphragm. So if you tilt them head up, the bowel contents will basically fall backwards towards their feet, and then you won't have the bowel contents pushing on this patient's diaphragm and on their lungs and making the problem even worse. So that's another reason why we tilt them. It's for the facial edema as well, obviously. So that's why we prone our patients. It helps their lungs immensely, takes that fluid away, gives the lungs more space to inflate, takes away the bowel contents and moves the heart as well. So that's not resting quite so heavily on the actual lungs itself. So there you go, ARDS and proning. I hope that was helpful. If you've got any questions, ask now or forever hold your peace. If you've got any questions and you see me walking about, please talk to me. I know I look grumpy, but I'm actually quite nice. Ruth, say yes.
Why are you picking on me? But yes, you are. You are. You do. You look grumpy, but you were very good at stopping and explaining stuff.
Yeah. So it's recorded. Just let your colleagues know that we've run the session. It's recorded and it'll be going on the YouTube channel. And I'm hoping to let everyone know the link to that later on today.
Thank you.
Bye, bye, bye.